And the connection of that to endocrinology is that most, if not all, endocrine diseases cause osteoporosis. So I will focus in this review on osteoporosis type of bone disease. And at the end, I probably will make time to touch on genetic bone abnormalities and not so well-known metabolic issues. So for all that, I hopefully can change the slide. Yes, I managed this much. So
you're doing great.
Thank you. In the good old age, we considered osteoporosis diagnosis based on bone density. And in the last 3-4 years, it became perfectly clear that this won't hold water. So now we say that it's low bone density combined with bone fragility. We don't treat the bone density. We treat the bone fragility in order to prevent sometimes life-threatening fractures. Just to mention, if you have a patient with hip fracture and it happens to be female, you have a 20% mortality. If it's a male, you have a 28% mortality within the first month. So this is not so benign. Low bone density can be a warning. In the past, we had defined primary osteoporosis in the first 10 years after the menopause, when people lose considerable bone density. And it's still true that if you have less bone, you are more prone to fragility. So I just saw today a patient postmenopausal in that window. Her bone density at the spine is T-score minus 4.1. He is at high risk for fracture. And then the majority of patients after this menopausal window come with secondary causes, which are very variable. It could be endocrine disease, rheumatological disease, GI, neurology, medication use like steroids and PPI and antidepressant. Many people come with profound vitamin D deficiency due to malabsorption or just lifestyle. And other than staying indoors, lifestyle factors can include smoking, alcohol, vegetarian diet, that's my main enemy, immobilization, muscle weakness, and surprisingly, some exercises as running can predispose to osteoporosis. And then there are the genetic defects, not very infrequently. So nowadays, when we evaluate a person, we are not just concerned about menopausal status, but we have to put them into fracture risk categories. If somebody has a low fracture risk, we advise lifestyle optimization and supplements. For people with moderate fracture risk, we frequently give anti-resorptive treatment, especially in the 10 years window after the menopause that we used to. We no longer give estrogen hormone replacement. We treat with vitamin D. And this is for people whose bone density T-score is less than 2.5. They are qualifying for pharmacological treatment. And the high-risk patients are the most interesting. We have now anabolic treatment modalities like Evenity or PTH analogs we can start with, and then we transition them into anti-resorptive. And of course, we always optimize vitamin D. And this is for people whose T-score is less than -3 and declining, have prior fracture or 3 or more risk factors. And what helps us to stratify is this online tool called FRAX, Fracture Risk Assessment. And you get a number for the major fracture risk and hip fracture risk. And the example here is for high-risk patients. If it's not that detrimental T-score, which was -2.0. So we can go from there to tell you why we treat these patients. First, you just notice that patients' posture deteriorates, they lose height, and then they develop kyphosis due to vertebral fracture. This is the most common spontaneous fracture. This is not induced by any trauma, but it's progressive and frequently painful. And fractures beget fractures, so the next thing is a hip fracture that the patient gets, which puts her into a wheelchair, and she loses her independence, and this could be even for male. It's not that terrible. But as my patient this morning complimented me for, we can treat even at that stage. He had 2 hip fractures before he came to me, and now he is fit like a 15 years old, can go around without any trouble, and just complains of memory problems. So it is hopeful, and our tools are getting better and better. And I will tell you about the miracles that we can produce. So it all starts by patients presenting to me, and preferably in person. And I can establish a good patient-doctor relationship, so trust with the patient. And that is frequently due to the physical examination. They can see that I really care about their bones because I touch them. And I collect a thorough history that includes many different factors. And then I start ordering studies. I order imaging studies, including bone density evaluation, and laboratory studies, including assessing urinary calcium loss, hormone levels, especially PTH and TSH. In younger patients, it's important to rule out growth hormone deficiency and type 1 diabetes that could lead to high fracture risk. Then I also assess their vitamin D level. And I don't necessarily wait for the lab to come back to replace it, because patients present with symptoms, I know they are deficient. I assess bone turnover markers to see how much the bone they lose, how much they gain, and CMP just to have a general metabolic understanding to see what treatment is permissible. I will tell you about these bone turnover markers because you usually don't use them, but it's becoming more and more important. For bone density testing is indicated for women if they are older than 65, and men if they are older than 70 for screening. And for anybody else, younger patients, if they have risk factors, which they usually have. This includes evaluation of hip and spine to get T-scores out of calculation, comparing the bone mineral density with the young person's bone mineral density. And we do this also to monitor treatment effectiveness. As patients gain bone density, their fracture risk frequently goes down. We do vertebral fracture assessment to recognize that the patient already is breaking bones. If the patient has high PTH, we do a forearm bone density, and we do a body composition analysis to evaluate for sarcopenia, growth hormone deficiency, and in young patients where the general hip spine bone density would not be applicable. And I forgot to mention to you that please interrupt me at will. And here, this is just a reminder of the hip spine bone density and the WHO classification of normal bone density, low bone mass, or osteopenia and osteoporosis. I think you all know this from medical school. And this is the image. It's a static quality image that we gain from vertebral fracture assessment. And we can recognize vertebral deformities, like in the insert here. This is buckling of the upper plate of this vertebra. And if I see this and also this wedge fracture above. I know patients will eventually break more bones, not just this. We used to do, which is no longer in the guidelines, so-called vertebroplasty, where some resins were injected into this type of vertebra to restore the height. And it was stopped because it turned out that you have soft vertebra below and above. And I have a patient who had a dozen vertebral fracture following kyphoplasty or vertebroplasty. So I would not recommend that to anybody. We have better ways of healing all the bones. Now, I told you that I will mention bone turnover markers. When we assess how much bone the person is losing in a day, we are measuring resorption markers, which are bone matrix degradation products. The CTX is less sensitive. The urinary entelopeptide is more sensitive if it's taken from the second urine of the day. And we can measure osteocalcium for bone formation, or procollagen N-terminal propeptide, or P1MP, which is a really good marker how much matrix is formed. Not all other markers are used here, but they are used at Mayo Clinic and elsewhere. And this way, I can assess if the patient needs an anti-resorptive because that person is in the high bone loss phase, or needs an anabolic treatment because the person has insufficient bone formation. Well, this is just a slide to give examples of bone turnover changes associated with secondary causes. Like if you have a patient with Cushing's disease or steroid treatment, you can expect low bone formation and increased bone fragility, candidate for anabolic treatment. If you have a patient with hypothyroidism, you have low bone formation, and if it's young enough, then growth retardation. And adrenal insufficiency is also low bone formation. On the other hand, if you have somebody with symptomatic hyperthyroidism, you should expect increased bone loss. The hyperparathyroid patients also have increased bone loss. Hypogonadal patients or ovarian insufficiency, or any sort of inflammatory diseases, they have high bone loss. Now, after I assess the patient and tell them that they have to go for testing, they come back with a number of questions, and the most frequent questions are, do I have osteoporosis? If the bone density was in the osteopenic range, they ask what it is. They always ask me what causes it. They prompt me to discuss pharmacological treatment. There is a 10-15% of patient population who would never take any medication because they heard in the news that it's really terrible, and they wouldn't get vaccinated either. And they enjoy hearing about non-pharmacological treatment options. And they ask me to elaborate on osteoporosis treatment adverse effects. And they always ask me how long the treatment is needed. So here are the non-pharmacological treatment options that I discussed with my patients. I have a really detailed dietary history, which is very useful. I calculate calcium and protein intake from the report that they give me. I assess their exercise, their medication use, smoking, alcohol, which I usually advise to stop. we discuss how to prevent falls and how to improve balance and what protective devices they can use, mostly for spine stabilization. And I do my very best to increase patients' muscle strength because that's closely linked to bone strength. And I do that by measuring walking speed, how fast they can stand up, or whole body composition analysis with DEXA. And the bone strength is strongly linked to bone loss and fall and fracture risk and disability. And I can increase with adequate exercise instruction and physiotherapy and help my patients regain independence. Vitamin D deficiency is something that you can almost enter to anybody's diagnosis list because it's so prevalent. And you can diagnose it by pushing on the tibia, and if the patient says, ouch, you can start high-dose vitamin D. Patients with vitamin D deficiency complain of back and knee pain, and that they are tired. And this actually goes away after 3 months of vigorous replacement. And what's causing it, that most of us are not sitting out on the beach, but sequestering in front of a screen. So I assume that many of the residents have vitamin D deficiency. If you care to push on your tibia, you would know. And there are many tests to measure the 25-hydroxyvitamin D level. Most of them are misleading. If you measure it with mass spectrometry, which is possible to order, I always order that, then you get a true value. And it's not uncommon that the radium assay shows you a really great vitamin D level in the 50s range, and then you do mass spec and it comes back to be 10, so which is very deficient. So if you really have a high suspicion, you need to measure it with a reliable method. I optimize vitamin D level to be in the upper half of the normal range, which is between 50 to 100 nanogram per milliliter. And as this very nice graph will show you, that vitamin D2 is increasing the initial 25-hydroxy-D, but it quickly goes away. And if you treat with vitamin D3, it can have a long-lasting and non-toxic effect. So one of my routine is to change from vitamin D2, which is curiously the prescription form. It's prescription required because it's so toxic. And vitamin D intoxication with vitamin D3 would only start if you give more than 40,000 international units a day. With vitamin D2, you can easily get intoxication at much lower level. And it's rare that you get intoxicated. I had one patient recently with a vitamin D level of 170 because she took 50,000 international units of vitamin D3 for 5 months every single day instead of once a week. She did not even have a high calcium, but her vitamin D level was really high. So I would clarify that it's not a daily dose. Now, in terms of pharmacological treatment, what you can expect that the bone mineral density would improve with oral anti-resorptive, you just maintain that you expect the fracture risk to be reduced, but the bone turnover normalized and the patient regain independence and quality of life. And there is a multitude of treatment that you can choose from. And you have to clarify with your patient what is their goal and tell them what the risks are, so you can set a treatment duration goal together. The options for pharmacological treatment comes in the category of anti-resorptive agents, which include bisphosphonates and the rank ligand inhibitor denosumab. One category of bone anabolic agents, which is PTH and its analog, PTHRP, or also called Stimulus. And the new one on board is a bone anabolic, which is sclerostin inhibitor. That's a monthly injection of Evenity. And I think the risk for heart attack and stroke has been overemphasized, and most people tolerate this treatment very well, and it will reduce bone resorption and nicely increase bone formation. So it's very effective. It gives you about 20% increase in bone volume in 1 year. Nothing comes without problems. So one of the problems that got much attention from the press, and it happens. I have every year 1 or 2 patients who took alendronate for more than 10 years. And when people felt that the patient took Fosamax long enough, then they gave IV bisphosphonate reclass. And then this subtrochanteric fracture happens. It's a spontaneous fracture, not requiring any trauma. And it's painful and debilitating and increasing with longer you give the bisphosphonate. I think bisphosphonate is safe for 3 years. After that, you have to think twice and maybe change the treatment occasionally. Thankfully, you don't have to wait till all the fracture fully develops. You can see the warning signs. The patient starts complaining about dull hip pain. And if you take an image of the femur on the upper part, you have this cortical thickening. And you can see that right below the trochanter. That's where the bone would eventually break. I tend to order bone density test just to see this part if I treat the patient long enough with anti-resorptive. And the other adverse effect of bisphosphonate is this osteonecrosis of the jaw. You can also see it coming by occluding the bone marrow cavity and eroding the cortical bone. And usually this problem comes in patients who have poor dental hygiene or they are subjected to dental surgery. And patients frequently are afraid that I need a crown. Do I have to avoid treatment for osteoporosis? And we can discuss what part of it is rational and what part of it is just fear. We have better things to do than just give bisphosphonate. The denosumab or Prolia treatment has many advantages, including that it will increase progressively the bone density by a position of bone at the cortical level. It has a very strong reduction of fracture. I hardly ever see patients who would get a fracture on Prolia. The great thing about Prolia that it's reversible after 6 months. You can do anything, it won't interfere. And it can be used in patients with kidney disease, if this is even stage 4. And the best part is that patients who have breast cancer, they get a very nice prevention of recurrence or metastases because this rank ligand inhibitor sticks to the breast cancer cells and make it impossible for the breast cancer cells to make their home anywhere in the body. They need this rank ligand for attachment, so the inhibitor of this will prevent metastases. I think that's about the best thing I can offer for the patient. there are negative things. If the dose after more than 7 months is missed, half of the patient will lose what they already gained in terms of bone. And you have a risk of hypocalcemia to deal with in kidney patients and patients with vitamin D is not at the level where you want that to be. Bone anabolic treatment can be with PTH analogs. The PTH analog itself, called Forteo, is only working on the spine, so it's best for patients who have vertebral fracture. The PTH-RP analog Timlos is restoring both the spine and the hip, and you give romosozumab or Evenity for people who have very low bone density and you are in a hurry to restore them. And this just shows you that the PTH analog Forteo is not working on the hip, but it's working on the spine. And this romosozumab is limited to 1 year because after that it loses effectiveness. And you have the risk of cardiovascular complications or low calcium, and you still can treat many patients with it. And this is how much bone you gain with Prolia alone or combination with Forteo. The combination treatment is more effective than any of the components alone. So if I have a really difficult patient, I have to add both an anabolic and an anti-resorptive. And this slide will show you that even a male dentist can get osteoporosis with chronic liver disease, vitamin D deficiency, history of fractures, family history of osteoporosis. And I had to convince this patient that osteoporosis is not a woman's disease, that he needs to get help. And he developed this osteoporosis due to hypogonadism and his liver disease. And now we got to the point where I have a few minutes left for genetic diseases that affect the bone. And these are features of Osteogenesis Imperfecta. You see the blue sclera here, maybe, and they have multiple deformities. And a patient who has a genuine Osteogenesis Imperfecta comes with 10 or more fractures a year. And we cannot really yet treat the gene defect, but they are working on it, the type 1 collagen. So it will be an RNA treatment very soon. And but we can treat the coincidental osteoporosis with that. Other variations for collagen defect is the Ehlers-Danlos syndrome that you recognize by a bunion, hammer toes, and joint hyperflexibility and scoliosis. And among other things, what I do is tell the patient to eat large quantities, more than 10 grams a day, of collagen powder, and that stabilizes their low level of endogenously produced collagen. And they like the effect on the skin. They don't like having wrinkles. And this is effective to reduce the calcium loss through the urine as well. Marfan Syndrome can also develop with scoliosis and these features. Unfortunately, you cannot do old-fashioned genetic testing because 32 genes could be involved for Ehlers-Danlos. So if you do the gene sequencing, you can request, I think my panel evaluates 27 genes, but at least it covers most of them. before you enter the diagnosis. Collagen is a connective tissue hormone that's produced in fibroblasts and provides elasticity to skin, GI tract, eye, vasculature, and bone. And if you want to increase the synthesis, you treat the patient with vitamin D and vitamin C, estrogen, or correct their hypothyroidism. And you can try to wean them off from glucocorticoids because that inhibits synthesis. And if you give dietary collagen, it promotes stability of your collagen. And here is another nice success story. If your patient has a hypophosphatemic rickets, usually they develop the deformities as children, and they have profound hypophosphatemia. And this is a very painful disease because they have a fracture every month or more. And you can now very effectively treat it with an FGF23 antibody, brosizumab, or also called Crysvita, which if you start at early age would prevent the growth retardation, fractures, and deformity, even starting in adult. And you can, especially in adult, you can prevent bone and joint pain, dental abscesses, and gait abnormality. I actually have 2 or 3 patients on this treatment, and they love me for it. This FGF23 is secreted from bone, but it affects the parathyroid, kidney, the vasculature, and heart. And abnormal secretion would be in the hypophosphatemic rickets, or it could also be in tumor-induced osteomalacia or CKD. I recently had an inpatient who had this tumor-induced osteomalacia. And if I see her back as an outpatient, I most certainly would initiate Crysvita treatment. Last, osteocalcin is a bone hormone, and it's regulated by vitamin D and vitamin C as well. And that affects glucose and the energy metabolism, reproduction, and cognition. So people who have lost their ability to check on their cell phone, they may have a really low osteocalcin level, which I can fix with vitamin D and vitamin C. And they may actually regain testosterone secretion as well. So if you get a low T, don't forget to check osteocalcin level before you replete that. And in summary, I wanted to tell you that osteoporosis is a wonderful topic for your practice. You would have a lot of fun treating patients with this because the success rate is very high. And you cannot completely cure osteoporosis, but you can reverse the bone loss, not just manage it. And treatment selection is based on history, physical exam, laboratory evaluation, and imaging, and should include both non-pharmacological and pharmacological modalities. And you can monitor your success with laboratory tests and bone density, which is gratifying.